where you are in the world, and welcome to this second webinar of this series of webinars by Interasma, the Global Asthma Association. I'm Louis-Philippe Boulet, I'm the president of Interasma, and I have the honor, in fact, to present Dr. Daniel Jackson, who is Associate Professor of Pediatrics and Medicine at the University of Wisconsin School of Medicine and Public Health. And Dr. Jackson will speak about the relationship between COVID-19, asthma, and comorbidities. So thank you very much, Dr. Jackson, to talk about this topic for us this morning.
Thank you, Dr. Boulet, for that kind introduction. It's my pleasure to be here this morning, afternoon, or evening, depending on where you're watching this from. I'd like to just share my disclosures. I do some consulting for a few different pharmaceutical companies, but it does not relate to what I'm going to be presenting specifically today. And then additionally, some of the work that I'm presenting has been funded by the National Institutes of Health, NIAID. So I just want to start with a little bit of background about SARS-CoV-2, which is the novel coronavirus that we all know has led to a global pandemic. The resulting illness from SARS-CoV-2 infection is termed COVID-19. And like SARS-CoV-1 and coronavirus NL63, SARS-CoV-2 uses the angiotensin converting enzyme 2, or ACE2, as its cellular receptor. The global burden of COVID-19 is remarkable. I pulled this information from Johns Hopkins on October 27th of this year. At that time, there were over 43 million global cases that had been recognized and more than 1.1 million deaths due to COVID-19. This global burden has led to really unprecedented efforts to enhance our understanding of this disease. A PubMed search on October 25th of COVID-19 and asthma led to 443 distinct publications. So this is a lot that has been coming out in a very short period of time. And what I'm going to try and do today is really hit many of the high points of this literature. So first of all, to have us all on the same page about COVID-19 and the associated disease characteristics, SARS-CoV-2 infection can lead to a wide array of disease severity, from asymptomatic infection to mild illness, severe illness, and, as you saw previously, also death. The time from exposure to this virus to illness is highly variable, reports typically from 2 to 14 days, with a median of 4 to 5 days. The most common symptoms of COVID-19 include fever, cough, and shortness of breath. But you can see it's also common to see fatigue, myalgias, and headaches. And one of the interesting features is loss of taste or smell that's been observed in subsequent studies, with some patients only experiencing this symptom without others. But what I'd like to highlight is that while these symptoms can be seen with COVID-19, you see there's also a lot of overlap with other respiratory viral infection symptoms, making it difficult to specifically distinguish COVID-19 by symptoms alone. So what about imaging that features that can be seen? So one of the most important things that happens with COVID-19 is the development of pneumonia. And this pneumonia tends to be associated with ground glass opacities. It typically occurs peripherally, and then you can see linear consolidations days into the illness as well, with this example that I showed here, with really quite diffuse pneumonia, highlighting the linear consolidations, and also while diffuse disease, it is more peripheral. So I want to spend a couple minutes to just briefly go through a bit of disease pathogenesis at a basic level for COVID-19. And this comes from a recent review article from JAMA. What's depicted here in this first slide is SARS-CoV-2 viral infection of host airway cells. And what you can see depicted on the right here are the cellular receptor, so the ACE2 receptor, and then also TMPRSS2, which is a serine protease that serves to activate the spike protein on SARS-CoV-2 and then allows or facilitates binding to the ACE2 receptor and entry into the cell. When we think about the pathogenesis of COVID-19, it's important to think about it across disease stages. So in the early stage of COVID-19 illness, bronchial epithelial cells, type 1 and type 2 alveolar pneumocytes, and capillary endothelial cells are infected, and an inflammatory response ensues. So this figure is showing the SARS-CoV-2 virus release, recruitment of T cells, monocytes, and neutrophils into the lung, and the release of a variety of cytokines, but here the inflammatory cytokines TNF-alpha, IL-1, and IL-6, which leads to an enhanced inflammatory response and tissue damage. Then, in later stages of COVID-19, particularly in those that develop more severe disease, what you see is a continuation of the inflammatory response, leading to alveolar interstitial thickening, increased vascular permeability, and edema. Interestingly, one of the things that often is seen as well is significant rates of T lymphocyte apoptosis. So you commonly will see a lymphopenia in more severe COVID-19. And also you see activation of coagulation pathways leading to microthrombus formation and an enhanced clotting that can be seen throughout the body. So what was the early experience of COVID-19 in China? This data was published in JAMA earlier this year and came from the Chinese Center for Disease Control and Prevention. And what you can see in this report through February of 2020 were about 72,000 cases depicted here. You also see the age distribution, which is unique with COVID-19, where there's certainly a predominance of adult patients with the disease. Also, the spectrum of disease is very wide, as I alluded to earlier. Approximately 80% of patients may have mild disease. 15% or so in this case had severe disease, and 5% were critical. And in this initial report, the case fatality rate was a little over 2%. Importantly, you see that the case fatality rate varies widely, with the highest rates seen in older individuals. When they looked in general at risk factors for case fatality, age, cardiovascular disease, diabetes, hypertension, cancer, and chronic respiratory disease were the tops on the list. Importantly, though, in these early reports, they did not distinguish asthma from COPD or other chronic respiratory diseases. So when we want to put COVID-19 in perspective in its relationships to asthma, I think it's important to set the stage by thinking about the link between virus infections, respiratory allergy, and asthma. And I really don't need to tell this group that when we think about asthma and virus infections, they are the cause of the majority of asthma exacerbations. So anywhere from approximately 50% in adult studies to 80 to 85% in many pediatric studies, exacerbations are associated with a viral infection. And it's important to remember that really any respiratory pathogen, viral pathogens such as RSV, influenza, or parainfluenza can precipitate an asthma attack. But rhinoviruses are the most common trigger of exacerbations in both children and adults. So what about influenza and asthma? There's certainly been a link between influenza, asthma, and more severe illness. And this data, I think, is important to have in perspective when I show you the epidemiological data related to COVID-19. So when we think about seasonal flu, and this is from 2016 to 2020 in the United States, approximately 20 to 22% of adults hospitalized for seasonal influenza had underlying asthma. And about 22 to 29% of children hospitalized for seasonal influenza had underlying asthma. So identifying asthma as a major risk factor for hospitalization due to flu, given that the rates of asthma within the United States are in the 8 to 10% range, depending on the age group you look at. Similarly, with our experience with the novel influenza virus H1N1 during the pandemic of 2009, asthma was the most common comorbidity in both children and adults that were hospitalized during the early phases of the pandemic, with nearly 30% of those hospitalized in this early report from the New England Journal of Medicine having comorbid asthma. We also know that when we think about risks for more severe illness in patients with asthma, that there's an allergy virus synergy, particularly in rhinovirus-induced wheezing and asthma exacerbations. This data, published almost 10 years ago, shows this pretty nicely in young children, where the probability of current wheeze when presenting to a hospital was much higher in patients who had demonstrable IgE to dust mite, and there was a dose response with this, if they didn't have a virus detected. However, the curve shifts both to the left and up in those that had a rhinovirus. So those that have a rhinovirus infection and very high IgE were very likely to have wheezing in this study. And why is that? Well, we know that type 2 inflammation impairs antiviral responses. And we also know that blockade of type 2 inflammation reduces rhinovirus infection duration and also risk of viral exacerbations. So, given all of this information that I just presented briefly to you related to virus infections and asthma, I think that it was quite logical that early on in the pandemic, asthma was listed right towards the top of the list as a major risk factor for COVID-19 at the onset of the pandemic. And currently within the United States, the CDC still lists moderate to severe asthma as a major risk factor for severe COVID-19. But I want to go through the data to put that in a little bit more perspective. So here's the epidemiology of COVID-19 and asthma. First of all, early reports from China, New York, and also US and Canadian pediatric ICUs really have not identified allergic diseases or asthma as major risk factors for severe COVID-19 in adults or children. There have been a few exceptions to that, including a large UK study which suggested that asthma may be a risk for COVID-19 related death. So I want to go through that study because I think it sets the stage for how we think about risk with COVID-19 in our asthma patients. So this came from the National Health Service of England and a study that they call Open Safely, which covers about 40% of the country. In this really large study, they examined about 17 million adults and 11,000 COVID-related deaths. And what you can see here is that, first of all, and I'm going to focus on the fully adjusted model over on the right here. But first of all, you see that age is a major risk factor for COVID-related death. So by far, the highest risk was in patients 80 and above, and relatively low risk in the younger populations. Additionally, they've shown that male sex provides significant increased risk for COVID-related death, and obesity additionally provides greater risk. When they start to look at respiratory diseases in this study, they first showed respiratory disease excluding asthma, and what you can see is that was significantly associated with increased risk of death. But when they started to look at asthma itself, in the less adjusted models, asthma was a risk factor whether they had recent oral corticosteroid use or not. But when they started to adjust for other comorbidities, what they show is that there was a modest increased risk of death in patients with asthma who had had a recent oral corticosteroid burst. So suggesting that not the major risk factor in these patients, but may confer some increased risk. So this really points to the fact that I think we need to be thinking more about asthma not as a single disease, but we know that this is really a syndrome with many different phenotypes and endotypes. And so when we think about personalized approaches to our patients, we need to think about how those may actually impact risk. This study was published in JACI fairly recently and used UK Biobank data, analyzing about 500,000 participants. In this study, the definition of severe COVID-19 was hospitalization. And when they defined allergic asthma specifically, they defined it by a comorbid diagnosis of allergic rhinitis, food allergy, or atopic dermatitis. And what you can see in this study is that asthma overall was associated with increased odds here at the top, increased odds of a severe COVID-19 illness. However, when they broke this down into allergic and non-allergic asthma, there was not a significantly increased risk for those with allergic asthma, whereas those with non-allergic asthma were at significantly increased risk for severe COVID-19. Similarly, the greatest risk was seen in those patients that had asthma and a diagnosis of COPD, or perhaps this would be an ACOS type population. So the fact that the susceptibility to severe COVID-19 likely depends on asthma phenotype, I think it's important for us to start to think about what mechanisms may link asthma phenotype to COVID-19 susceptibility. First of all, I think it's important to consider how SARS-CoV-2 infects patients. And this very outstanding study from Rick Boucher and his team was published earlier this year in Cell, and provides us some very important information about susceptibility to SARS-CoV-2 infection across the upper and lower respiratory tract. And what they showed was, first of all, a gradient of infectivity from the upper to lower airway. And this gradient of infectivity relates strongly to also a gradient of ACE2 expression, the receptor for SARS-CoV-2. So the receptor expression is much higher in the upper airway compared to the lower airway. Furthermore, they show that ciliated airway cells and AT2 cells are the primary site of infection with SARS-CoV-2. And they conclude that lower respiratory infection likely occurs through viral aspiration. Thus, I think it's really important to understand that conditions impacting the upper airway are likely relevant to COVID-19 susceptibility for that initial infection. So this raises the question, is ACE2 expression important to COVID-19 risk? As we've talked about, ACE2 is the receptor for SARS-CoV-2, and the serine protease TMPRSS2 also is important in facilitating viral entry, but there's been some very nice studies that show that ACE2 is the most important component here. Furthermore, I showed you some risk factors for severe COVID-19, such as hypertension, cardiovascular disease, diabetes, and obesity, along with smoking. And importantly, all of these have been associated with increased expression of the SARS-CoV-2 receptor, ACE2. Furthermore, this data from Sapinda Bojanovic, published earlier this year in JAMA, looked at nasal ACE2 expression and showed nicely that it varies by age. So clearly, younger patients are at lower risk for severe COVID-19 illness, and there's likely a variety of factors for that. But this raises the question that one of those factors could actually be lower ACE2 expression in children versus adults. And what you can see is this dose response across the ages, where those under 10 had the lowest expression of ACE2 and those 25 and above with the highest numbers. There are some limitations to this, that they didn't have the population which is at greatest risk for severe COVID-19, which would be those above 65, 70 years of age, and a relatively small population of adults. Nonetheless, this fits quite nicely with the epidemiological data. So now when we think about asthma, I think it's important to ask the question, does asthma or respiratory allergy impact ACE2 expression in the airway epithelium? And we wanted to address this question earlier this year, back in April of 2020. And we raised the hypothesis that a potential explanation for the observation that asthma and respiratory allergy have not been identified as a major risk factor for severe COVID-19 disease is a reduced ACE2 expression in airway cells and associated decreased susceptibility to infection. To examine this, we use bank samples from the Urban Environment and Childhood Asthma, or EURECA study, which is part of the Intercity Asthma Consortium. This is a birth cohort that had prenatal enrollment, and 318 of the children in EURECA had nasal epithelial brushes obtained at 11 years of age. We additionally had asthma diagnosed at age 10, along with repeated allergic sensitization assessments over time. and cross-sectional assessments of type 2 biomarkers, so we could look at relationships amongst all of these. And this slide shows the relationships we observed with allergic sensitization and asthma in relationship to ACE2 expression. On the left side of the screen, what you can see is, first of all, in black here are patients that had neither asthma nor sensitization to aeroallergens, and you can see their ACE2 expression here. And allergic sensitization alone was associated with a reduced ACE2 expression compared to those that weren't sensitized. Importantly, you see that patients with asthma but no sensitization had very similar ACE2 expression to those without asthma. And furthermore, the patients with asthma who were also sensitized to allergens had the lowest ACE2 expression. We wanted to look at this a little bit further within the asthma population. And what you can see here is really a dose response with sensitization. So on the far left are those with asthma with no or minimal sensitization. And as you progress to increasing amounts of sensitization to aeroallergens, or more type 2-ness, if you will, you see a significant reduction in ACE2 expression, which is quite large, so in the magnitude of almost 1/2. So what about relationships between type 2 inflammatory biomarkers and ACE2 expression? On this table, what we show is that there are significant negative associations with the number of positive allergen-specific IgEs, the total IgE, exhaled nitric oxide, as well as nasal epithelial IL-13 expression, and a trend for blood eosinophils. So all of these type 2 biomarkers are associated with reduced expression of ACE2. The next question we wanted to ask was, what is the impact of allergen exposure in allergic individuals on ACE2 expression? To examine this, we turned to two different cohorts. One was a study from the Immune Tolerance Network that looked at basically cat nasal allergen challenge by an environmental exposure chamber. And they looked at upper airway epithelial responses there. So they had 24 adults with allergic rhinitis to cat and no asthma symptoms in the past year. They had nasal epithelial cells that were collected at baseline and after nasal allergen challenge. And then they had also after environmental exposure chamber challenge, or EEC. They did RNA-seq analyses of the upper airway epithelium. And what you can see on this slide is that when we looked at the upper airway ACE2 expression, that both nasal allergen challenge as well as the environmental chamber challenge were associated with approximately 20% reductions in ACE2 expression in these patients that had underlying cat allergy. So next, we wanted to look at whether allergen exposure could impact the lower airway epithelial responses. And this study, led by my colleague Bill Bussey here at the University of Wisconsin, looked at segmental allergen challenge and lower airway epithelial responses. They studied 23 adults with mild asthma, not on controller therapy. And then bronchial epithelial cells were collected at baseline and then after the segmental allergen challenges, either to cat, dust mite, or ragweed, depending on their pattern of allergy. Then RNA-seq analyses of the lower epithelium were performed. And what you can see here is that allergen challenge significantly reduced ACE2 expression in the lower airway as well. So we next wanted to look at what components of type 2 inflammation actually reduce ACE2 expression. And this was pulled from publicly available data, looking at IL-13 treatment of both upper and lower airway cells in vitro. And what you can see, first of all, is that the ACE2 expression is significantly higher in the nasal epithelium than the bronchial epithelium. But in both cases, treatment with IL-13 significantly reduced ACE2 expression. And there have been other groups that have published similar findings since we first reported this as well. So in terms of the relationships of ACE2 and type 2 inflammation, what I've shown you is that allergic sensitization is associated with reduced ACE2 expression in airway cells, and ACE2 levels are lowest in those with both high levels of allergic sensitization and asthma. Asthma without allergic sensitization is not associated with changes in ACE2 expression in airway cells from the Eureka children. And then furthermore, controlled allergen exposure further reduces ACE2 expression in both the upper and lower airway epithelium. So what other factors impact ACE2 expression in the lower airways? This study comes from the SARP, or Severe Asthma Research Program, funded by NHLBI. And they looked at factors associated with ACE2 and TMPRSS2 expression in asthma. They used sputum gene expression analysis of 330 SARP participants and 79 healthy controls, and found really no difference between their asthma cohort and the healthy controls with either ACE or TMPRSS2 expression. But they did show higher ICAM1 expression, so the major receptor for rhinovirus, receptor for the major group of rhinoviruses was higher in patients with asthma versus healthy controls. But I think some of the important things that they found in relationship to ACE2 expression was significantly higher expression in males, in African American patients, and in those with history of diabetes. So importantly, all of those have been associated with more severe disease with COVID-19. The next thing that I think is important from this study is looking at the association of inhaled corticosteroid and systemic corticosteroid on sputum ACE2 expression. And what you can see here on the left is that when they looked at ICS doses, that basically the higher the dose of ICS, the lower the ACE2 expression within the airway within the sputum cells of these individuals. And then furthermore, they looked at pre and post systemic corticosteroid use. So the systemic corticosteroids were given by triamcinolone injection. And what you can see was that pre and post systemic corticosteroids, they did not see a significant impact of the systemic corticosteroid on ACE2 expression. So that data was from sputum. Now I'm going to show you a bit of data from Sally Wenzel's group looking at bronchial epithelium. And here they show that a T2 low asthma phenotype is actually associated with enhanced ACE2 expression in the bronchial epithelium. They define T2 low asthma by eosinophil counts of less than 150 or less than 300. It varied a bit in the study. But what I'm showing here with the figure is a comparison of ACE2 expression to, on the left, the mean T1 gene expression. So they have a panel of different genes that are associated with type 1 inflammation. And you can see a positive correlation between ACE2 expression. So the more T1 gene signatures that they saw, the higher the ACE2 expression. And conversely, using the T2 gene expression mean, you see an inverse correlation. So the higher the T2 gene expression, the lower the ACE2 expression. And importantly, they identified IL-1, IL-6, and interferons as potential therapeutic targets in severe COVID-19, based on the fact that these T1 pathways very much associated with both risk factors for severe COVID, which include male sex, hypertension, but also associated with the ACE expression observed here. So clearly more data are needed to understand disease transmission, susceptibility factors, and mechanisms across ages and by asthma phenotype. Everything that I've shown you to date are associations that don't relate to the actual specific infection rates and disease severity observed. So this study, which is ongoing, I think is going to shed a lot of light on the epidemiology, but also host response and risk factors for SARS-CoV-2 infection. The study is called HEROES. It's an NIAID funded surveillance study of children and young adults in 13 studies previously funded by NIH, and also their household members. So the goals here are to identify rates of infection in children and their family members, determine proportion of infected who develop symptomatic COVID-19, and importantly to this talk, determining whether rates differ by asthma or underlying allergic diseases. And because many of these cohorts have focused on asthma, about half the population here in this study has underlying asthma. The study was designed as light touch, meaning no in-person visits. It is including every 2-week nasal samples and samples during illnesses, initially for 4 months, but now has been extended for a 6-month period of time. There are stool samples obtained, as well as baseline serum and convalescent samples, and electronic data collection. So no in-person visits. This was rolled out in an extremely rapid time frame, and I think will provide us with very exciting data. I'm just going to show one example of the type of data that is going to be available from HEROES, and this is unpublished data, looking at basically two separate households, one with a 7-year-old child and a 42-year-old parent. And basically what you see with yellow are symptomatic patients versus not, and then the values where there's a number within these different areas are the CT values. So the lower the number, the more virus there is. And what you can see here in household 1, that both participants had negative collections on June 19th. Both were positive on July 3rd with basically quite high values. And they also had persistent symptoms that went on beyond out to a couple weeks. And you see resolution here by the end of July. Household 2 looks very interesting. So the symptomatic patient is the 45-year-old adult. We have a 17-year-old child that never was infected during the course of SARS-CoV-2 moving through the household. And then we had another adult that was initially asymptomatic with quite high amounts of virus, but then became symptomatic and had some persistent symptoms. But importantly here is this 14-year-old child had very high amounts of SARS-CoV-2 in their upper airway, but they were asymptomatic throughout. Asymptomatic, yes, but with these sorts of levels of virus in their nose, they certainly could provide significant risk of infecting others. So I want to move forward, shifting gears a bit to talk about what has the impact of COVID-19 public health measures been on asthma. This study came from Children's Hospital of Philadelphia and was published earlier this year, and looked at basically over time what the various public health interventions, so mask wearing, closing down schools and the other measures that occurred, what impact they had on asthma disease activity. And on the left here, what you can see are asthma encounters over time. And they used the 5 prior years with the dates January through March and then March through May. And you can see outpatient visits were quite stable across those timeframes in the previous 4 years. And they dramatically dropped from March to May of 2020 after the public health interventions went into place. Similarly, hospitalizations dropped significantly after these health interventions went into place. And the shift so telephone visits remained common, but one thing that changed dramatically was the development of video visits. So 60% of the encounters for asthma occurred by video visits over that time frame, which has continued to be the case as we've moved forward through the pandemic. But strikingly, when you look at the numbers, what they saw was an 84% reduction in ED and inpatient visits for asthma, and about an 80% reduction in oral corticosteroid prescriptions. So remarkable drops in asthma activity in the pediatric population based on these public health interventions to limit SARS-CoV-2 infection. So what else did they limit? Well, they limited other respiratory virus exposure. So here they look specifically at rhinovirus. And we know that rhinoviruses are a major cause of asthma exacerbations in children. And you can see that with the institution of these public health measures, a dramatic drop compared to historical trends in terms of the rates of rhinovirus infections between the 2015 to 2019 period for March through May versus the 2020 March through May period. Additionally, what they showed in this paper was an abrupt ending to influenza A and particularly influenza B seasons, which were observed as well based on these public health measures. So this study looked at a variety of factors, and this is a summary of the impact of COVID-19 public health interventions on asthma disease activity. So again, this includes masking, stay-at-home orders, social distancing, and the closing of schools. And what you can see is that after these were instituted, there was far more video telemedicine, many fewer asthma encounters for acute asthma, many fewer courses of oral corticosteroids, and as a potential explanation, fewer other virus infections. This study also looked at air pollution exposure and did not find a strong association of air pollution exposure being different during this time window compared to other years. Although there are other studies out there that have clearly shown with the stay-at-home orders a significant reduction in pollution exposure as another potential explanation for reduced asthma activity during the pandemic. An additional possible explanation relates to medication adherence during COVID-19. So patients with COVID-19 being a respiratory disease obviously have had a lot of concern about their risk of severe illness with COVID-19. So this looks at both asthma and COPD patients and uses the Propeller Health electronic assessment of adherence. And what you can see, and this is over a fairly short period of time, but within the onset of the pandemic, you see about a 15% relative increase in adherence. And this was looking at about 7,000 patients with asthma and COPD. So while 15% increase in adherence for an individual may not make a huge difference necessarily at a population level, this is a dramatic change and very likely contributes to what's been observed in terms of the reduced asthma morbidity during the COVID-19 pandemic. So the thing that I'll finish with this morning is talking about asthma management during the COVID-19 pandemic. And really the reason why I didn't spend more time on this particular part of the talk is because this is really based on expert opinion. There are no randomized controlled trials looking at asthma patients that have been reported to date related to COVID-19. So I'm going to show you the data that's available and what the recommendations are based upon. But again, relatively limited data to this point. One thing I think that's important to remember is that it's more likely for a patient with asthma to have an exacerbation of their disease due to non-COVID triggers, so such as other respiratory viruses, allergens, pollution, or medication non-adherence, than it is for COVID viral infection to cause an asthma flare. So in general, consensus recommendations encourage the continued use of asthma therapies and trigger avoidance during the pandemic. So these include controller therapies such as ICS and biologics. But clearly further data are needed to define the impact of asthma therapy to COVID-19 disease outcomes. This is an important piece to keep in mind. So the use of systemic corticosteroids. And this data that I'm showing was published in the New England Journal of Medicine looking at dexamethasone for the treatment of COVID-19. So not for the treatment of asthma, but for the treatment of COVID-19. And they studied hospitalized patients with COVID-19. And I think what it's important to note when you look at the figure on the right is when they did the analysis across all participants, you saw about a 17% reduction in mortality with the use of dexamethasone added to usual care versus usual care alone. But importantly, this effect really depended on severity of disease at the time that the patients presented for the study. So in panel B here, they looked at invasive mechanical ventilation. So those that were being mechanically ventilated at the time that they entered the study, you can see a very significant reduction in mortality, about 35% in those treated with dexamethasone versus those with usual care. So going a step down in severity to those that were requiring supplemental oxygen, you can see here there was also a mortality benefit of about an 18% reduction in mortality in those that were treated with dexamethasone versus usual care. Importantly, the 1,500 patients that were not on oxygen, so they were hospitalized but not requiring any ventilatory support or oxygen, they actually had a non-significant difference in mortality, but trended to be higher, about 20% higher in the dexamethasone group versus usual care. So what they showed clearly was mortality benefit in more severe disease, but the authors themselves conclude that their data is compatible with harm for less severe disease. So why might that be? Well, for one thing, there's concern that it could increase viral replication early in SARS-CoV-2 infection. So that was shown. Systemic steroids do increase SARS-CoV replication. So if this is done early on in illness, it could actually potentially lead to worse outcomes. So I think that this raises the point that we should be cautious in terms of use of systemic corticosteroids in our asthma patients. We certainly should use them if they're having an asthma exacerbation that is severe enough to require systemic corticosteroids. But using them early for the treatment of COVID-19 without asthma exacerbation should really be cautioned. So what about inhaled corticosteroids? Basically, we all know that ICSs are essential to prevent loss of control in asthma exacerbations for many patients. And the use of them is certainly important during the pandemic. So it prevents the need for systemic corticosteroids. And I just showed you some concerns about systemic corticosteroids and SARS-CoV-2 infection, at least early on. And they also prevent visits to healthcare facilities, which also is certainly desirable during the pandemic in particular. So there's some data that show that ICS is associated with reduced ACE2 receptor expression in sputum, the data that I previously showed you, and also in some ex vivo ALI cultures from COPD patients. But there's really no currently available clinical data that I'm aware of to demonstrate relevance of this to risk of COVID-19 illness. Thus, taking this all into account, consensus recommendations are to follow current evidence-based guidelines for the use of ICS for the treatment of asthma. So another important area is the use of biologic therapies. And this review, a consensus statement from the World Allergy Organization, basically raises two important questions when we think about biologics. First of all, do biologics alter risk of SARS-CoV-2 infection? And additionally, once infected, do biologics alter severity of illness? So there's some reason why people have had some concern about this. I showed you the relationships of type 2 inflammation with the potential for modifying disease risk in COVID-19. There are early reports that suggest eosinopenia as a risk factor for more severe COVID-19, although unclear whether that's the result of the illness or a risk factor up front. We also know, though, that biologic therapies are highly effective for the prevention of loss of asthma control and also exacerbations. And data is limited, but a recent Belgian registry study published in the ERJ suggests no increase in risk of COVID-19 with biologic use. Their registry was limited to anti-IgE and the anti-IL-5s, just of note, but again, reassuring from what they've put out to date. So clearly the consensus recommendation at this point is to continue the use of biologic therapies in patients with a clear indication and history of benefit. So I'm going to end there. I'd like to thank you all for your attention today, and I'd be happy to answer any questions you have or comments.
Well, thank you very much, Dr. Jackson. It was a superb presentation. We have a few questions already. You spoke about the ACE2 receptors in the upper airways and some potential protective effects of inhaled corticosteroids for asthma. Do you think we can think that nasal ICS could be protective? Theoretically, there are probably no data on that.
So it's a good question. There aren't data on that, and there is some question that if you reduce the type 2 inflammation with ICS, whether it's nasal or inhaled, might you actually sort of counteract any differences that might be observed with the corticosteroids themselves? I think it's an important question and something that should be looked at further.
And from your review of the data on COVID and asthma, is there any risk factor of smoking or secondary smoking for children or other type of indoor pollution, for example, on the prevalence or severity of COVID? Any data on that?
So I'm not aware of specific data on that. In general, there is some data that pollution can increase ACE2 expression, and similarly smoking can. But I'm not aware of any epidemiological data to specifically link it to this point. It is one of those things that we may be able to learn from our HEROES study that is going to be following, over this longer period of time and identifying risk factors for infection and more severe illness.
Yeah, that's right. Thank you. And I have another one. There are many factors acting on the ACE2 receptor, such as drugs, diet, and particularly in adult or in the elderly. Of course, do you think this may have really a relevance? Can it be a modulator? Or I think that we had some data on hypertension and heart diseases, I guess, with some medication associated to that.
Yes, it certainly got a lot of attention early on in the pandemic. The ACE inhibitors in particular dramatically modulate ACE2 expression. People have looked at that to see whether use of ACE inhibitors or ARBs for the treatment of hypertension would be associated with worse outcomes, and they did not find that to be the case. So I think, as the question points out, this is a really complex area. There's really very little direct data. It's really associative data that we've looked at, and I think it's important to take it to some of those next steps in terms of that understanding.
Yeah, I think we still have a lot to learn about this condition, of course, this disease. I don't see any other questions for now. No, I think we had. So there was a comment about the protective effect of allergy. With the challenges, in fact, it seems to reduce the ACE receptor activity or something. So some people can consider that the allergic responses can be protective or can be beneficial, but on the other hand, a good control of the disease is also extremely protective. So I guess there is a counterbalance here that we should have, and the control is the mainstay. I guess it's the best thing to do. Absolutely.
And as we've talked about, these are it's a complex situation, a lot of factors that are impacting things, and we have much more to learn. Ultimately, as I started with, there are over 400 publications that have come out in 2020 on this topic. In fact, there were 15 more that came out between Sunday and yesterday. So it's a rapidly evolving area, and I think we have a lot more to learn. As I said, no randomized controlled trials to date, so there's a lot of association studies, and in terms of the level of evidence, it's overall on the low side. So definitely more is needed to help take care of our patients with asthma and patients in general in the pandemic.
And I think this will be the last one. There are not many studies also on the long-term effects of COVID, even in young patients or young asthmatics. Some patients complain of long-term dyspnea or shortness of breath, difficulty to control asthma after COVID, although this is quite variable from a patient to the other. There have been suggestions of damage to the lung over a long time. Do we have any data on that, or what is your experience with that? Those who have the disease sometimes can persist with symptoms for many weeks or many months.
So, I'm a pediatric allergist. My general patient population of children have less severe COVID-19 illness in general. So I haven't had really many patients that have had more long-term symptoms, but certainly I'm aware of that. And I think there's been very little study of the long-term ramifications, in part because there are, it hasn't been very long to this point. But will be very important to follow these cohorts out in the long term to understand the long-term ramifications of COVID-19 illness.
Well, excellent. I think we don't have any more questions. Well, I think we'll stop there, and thank you so much for this presentation. I'm sure many people will listen to that once again over the next few weeks because it's recorded. And thank you to everybody who attended this session, and thank you so much, Dr. Jackson, for taking time to present to Interasma. Thank you very much.
Thank you.
Have a nice day.